All right. Good evening, everyone, and good morning to just one person, I think, but good morning to you. Welcome to the Governing Council meeting. I'm very pleased to co-host this GC meeting along with Dr. Prasada Rao, our Governing Council member. This GC meeting is a special one as we've invited the partners of the collab, which is more than 300 organizations across the country, to learn, observe, and ask questions to a very eminent set of experts who will share with us the epidemiology and trends of our current pandemic. Before I hand over to my co-host, I'd like to quickly introduce my co-host and our panelists. Dr. Prasada Rao, everyone knows you, but he's a former Union Health Secretary, Government of India, and Special Advisor to UNAIDS, the Special Envoy to the Secretary General of the United Nations on HIV/AIDS for the Asia Pacific. And he's a member of the Governing Council of the COVID Action Collab and been closely engaged in the COVID response as an advisor to West Bengal, among many other roles that he's playing. We also have with us Dr. Nimalan. Dr. Nim has a fairly long name, so we will call him Dr. Nimalan. He's a reader at the MRC Center for Global Infectious Disease Analysis, School of Public Health at Imperial College in London, and he's joining us from London at the moment. Dr. Sandip Mandal is a scientist at the Indian Council of Medical Research in the Clinic Studies, Trials and Projection. Dr. Gangakhedkar is a distinguished scientist and former epidemiologist at ICMR. And I'm very pleased to have and welcome our Governing Council members as well and partners of the COVID Action Collab. Before I hand over to Sir, I would like to just inform you that we are recording this session, and if you have any questions, it'd be great if you could put that in the chat box so we can collate and facilitate the session going onward. We will have a good 20 to 30 minutes on questions and answers, and won't spill over with presentations. So this is your platform to ask the questions, and our experts will answer you. Over to you, sir.
Thank you very much, Angela, and good afternoon to all the Governing Council members, partners, and our distinguished experts who have joined us today. This collaboration has been doing a lot of COVID response work in almost pan-India, not just in Karnataka, a number of states for last year and a half or more. And the most recent, of course, is the second wave, which we have passed through. We still don't know whether the second wave is over, but we are also already talking about the third wave. So I think it is time for us, as both council members and also as partners, to sit back and understand, I think with an open mind, as to what is the epidemiology behind this epidemic, how the second wave is moving, and whether it has come to an end in India, or is there a third wave, the spectrum of a third wave, is it there for us? I think it's good to know from the experts as to how the epidemic is progressing and what are the risks, what are the opportunities, and also most importantly, the vaccination, what important role the vaccination is going to play a part in this. That is the basic objective. So to put it succinctly, I think understanding the epidemiology, current status of the epidemic, genomic sequencing is another area where we would like to know a little bit about the variants, various variants which are coming in one after another, and also especially about Karnataka. I think Dr. Mandal will be talking about Karnataka because some of us, not all of us, but many of us are in Karnataka, and Karnataka's response has been fairly good. It may not be in the top one or two, may not be at the bottom also, but it has been fairly consistent over a period of time. So to understand the epidemic characteristics in Karnataka and some projections into the future, and also the role that vaccination is going to play, and also what does it mean for the vulnerable populations, because this collaboration essentially works with the poor and vulnerable populations who are bearing the biggest brunt of the epidemic, even the first one and the second one also. So what is the impact of this on the vulnerable populations? How the vaccination can help? What are the access issues? Some of them also are important for us. And maybe I think our partners would be very keen to know some of them from the experts. So basically, this is the structure. that we have for the meeting. We have presentations by Dr. Neem and Dr. Mandal first. And later on, Dr. Gangakhedkar will receive questions from the partners, and he will try to answer some of them. And after that, we give the floor to the governing council members who can share their thoughts, who can also ask questions. So we keep a lot more time for question answers than just for presentations, as Angela has said. So without further ado, I will now request Dr. Nimpathy to make his presentation. He will be presenting on the projection, the structure of the epidemic, how it is progressing. So yes, over to you, Dr. Pathy.
Thanks, Dr. Prasada. I hope my slides are visible and I'm audible. Yeah, great. Yeah, so first of all, thank you very much for the opportunity to come and speak to you folks about the situation so far, but also some of the work that we've been doing at ICMR and in collaboration with Imperial College. So this is all, myself and Sandip, we both work in a unit called Chromic, based at ICMR, which stands for Collaborative Health Research and Modeling between ICMR and Imperial College. And so what I'm going to do is I'll like to start with just a few very quick observations about the progression of the COVID-19 epidemic so far in India as a whole. And then I'd like to hand over to Sandip Mandal for to tell you a little bit more about some of the mathematical modeling that he's done that's relevant to Karnataka. So just a couple of quick points that I'd like to touch on. Firstly, just a very quick look at the trajectory of the COVID-19 epidemic so far in India. I think it's certainly taken a distinctive progression when we compare it to other countries, especially compared to here in the UK, where I'm based. And also, when we're looking at future scenarios, it's really important to take account of immunity and the potential role that immunity might play in how the epidemic may unfold in future. So it's worth taking a brief detour to look at some of the implications of vaccination and immunity. Thirdly, there's been some discussion about the long-term prospects for COVID-19. Sometimes in the popular media, for example, certainly here in the UK, we hear questions of, do we have to have indefinite lockdowns and releases and so on? Or rather, what should we expect for the long term of this disease? And when we hear about managing the burden of COVID-19, what does that really mean? And so I'd like to think a little bit about that. And finally, some initial thoughts on the short-term future for the epidemic and whether we should be concerned about a third wave. At that point, I'd like to hand over to Sandip, who has done a whole bunch of modeling basically related to this question. So I'm going to be brief because I agree discussion is perhaps the most important part of this. But here's a figure that I stole from Google, and this in turn is basically drawn ultimately from the data that's reported, the official testing data that's being reported from India. And so everyone would be familiar, I hope, with this overall shape of the epidemic. There's this initial peak in last year. It was a very slow burn epidemic, this first wave, if you like. And then, of course, as we all know, we had this much more explosive spread in at the beginning of 2020 that thankfully peaked and has come down now to much lower levels of infection. Dr. Prasada mentioned earlier, we're not quite yet sure if the second wave has finished. And the continuing levels of infection here, I think, are still a reason for concern. But some of the interesting observations that we have when we compare these two, if we look at this first wave, it was really curious in India that it seemed to be relatively mild. And when I say mild, I mean in terms of its rate of spread, in terms of the burden that is placed on the healthcare system. So remember, at the same time in Italy, in the UK, especially in American cities like New York, there was devastating spread of the virus. And so we and others are estimating that the basic reproduction number was only around 1.2 to 1.4. Now, for those of you who are not familiar, the basic reproduction number, it basically tells you with every person that gets the disease, how much they amplify the disease. So how many secondary cases they cause on average. And so it was relatively low if you look at the available epidemiological data, around 1.2 to 1.4. And bearing in mind that in countries in Western Europe, for example, it is being estimated that R naught for the first wave in those countries was as high as around 2.5 to 3. So there was a rather interesting sort of a different epidemic dynamic playing out. Another noticeable thing was that transmission is what we call heterogeneous, which is that not everybody was equally infectious. And in fact, there seemed to be evidence that there was only a small proportion of people that were responsible for the majority of transmission. And there's some parallels here maybe with wealth distribution in various countries, for example. It was very similar to those sorts of distributions. There were many, many people who tested positive for SARS-CoV-2, but who didn't have any evidence of having infected any of their contacts. And yet there were other people who tested positive and had infected all of their contacts. And so it was a very patchy sort of spread. And we also saw in that epidemic, at least on the country level, that rural areas were seeing substantially less infection than urban. So at the country level, I think seroprevalence was roughly around half in rural areas than in urban areas. I think Karnataka was an interesting exception where it seemed to be comparable. And as far as I know, we don't yet fully understand why there was that difference. But if we compare this then against the progression of the second wave, and so I've said here February 2021 to July 2021, because again, it's unclear how the future might progress. But here we saw much more explosive spread. So R naught, this amplification number that I described, has been estimated as being between 2.5 to 3, which is in epidemiological terms actually substantially higher than what we saw for the first wave. And on the other hand, whereas for the first wave we saw patchy transmission, in this case, at least anecdotally, we saw instances of whole households getting infected, and much more commonly than they were during 2020. And of course, rural areas saw a lot more infection activity than in the first wave. So as we now know, a lot of this is really attributable to the emergence of a new virus, a new variant that was later called the Delta variant. So this is the same as earlier it was called B.1.617.2. WHO then made these much easier designations to refer to these viruses with. And so the Delta variant has turned out to be much more infectious than the previously circulating virus. If you compare it to the virus that first emerged from Wuhan in China, it's estimated to be roughly twice as infectious as that, and perhaps 40 to 60% more infectious than the Kent variant, which was circulating back in 2020. And so, this new virus basically caused this completely new epidemic wave. So, so it's worth thinking a bit, as I mentioned, about immunity and vaccination. This is a very nice figure from The Economist. So here in the UK, vaccination rates have escalated pretty quickly. Of course, we're a much smaller country than India, and so it's possible to reach high population level coverages much sooner. But here's the kind of picture that I hope we'll see in India soon, once vaccination coverage also reaches very high levels of the population. So it's a slightly complex figure, so I just wanted to talk you through it. So on the left-hand side is the number of cases that are being diagnosed. And you can see here our severe winter wave of COVID-19 that happened. And in the middle is hospital admission, and on the right-hand side is the number of people who are dying from COVID-19. And this red line is basically when vaccination started, when the vaccination program began. And you can see in all of these, there was this very severe wave that happened in the winter months. So a lot of people getting infected, a lot of people getting admitted to hospital, and a lot of people were dying from COVID-19. However, it's quite interesting when we look at the forward projection of the epidemic. So this was basically after restrictions were lifted, we saw then an escalation in the number of infections, and this was basically the start of the third wave in the UK a few weeks ago. But and you can see that infection came up to about the same level as the severe winter peak that we saw before. But if we look at the same data in terms of hospital admissions and new deaths, you can see that the admissions and deaths never came up to the same levels as they did in the earlier winter peaks. And of course, a major reason for this is that people were getting vaccinated. And by this point, we'd reached the stage where 95% of the elderly, the over 65s, had received at least one dose of vaccine. And so this was strong evidence from the UK, from Israel, from other countries similarly, that the vaccination program is having a strong effect in terms of protecting people from severe disease, as well as protecting people from dying from the infection. So in short, the vaccines work. They possibly protect against infection as well, although there's still evidence being collected about that. And the important thing is 2 doses, and this applies to many of the available vaccines, AstraZeneca, the mRNA vaccines, and even, I believe, Covaxin as well. That 2 doses of these vaccines are protective against the new Delta variant. So there's been a lot of news about the lifetime of vaccine-induced immunity. And for those of you who are not familiar, this basically involves taking blood samples from people who have been vaccinated and examining this blood for antibody. And so there are several headlines about, antibodies are waning after 2 months, after 3 months, and so on. And so it's easy to conclude from that immunity is only very short-lived. But there's a but here. And so the major thing to remember here is, despite all of these findings, when we think about effective immunity, and that is whether you're protected against COVID-19 or not, this is actually more than just detectable antibodies. And there are other elements to your immune response that actually these tests don't actually pick up. So 2 of the particular ones are, for example, memory of antibodies. So you may get to a stage where all of your antibodies are undetectable in your blood, but there is still memory in bone marrow, for example, and in other compartments in the body, so that you can mount a quick immune response when your body experiences this pathogen once again. And another important aspect of this is a part of the immune response that we don't often talk about, which is what we call T-cell immunity. And again, T-cell immunity is not detected by these antibody tests. And it's quite likely that people have lasting T-cell immunity as well. That means that their overall protection against COVID-19 is longer than the few months that has been suggested by these different headlines. So we don't know yet for sure, but just a caution when interpreting these headlines. And so, so I mentioned, this question on whether COVID-19 would be an indefinite threat. And the short answer is unlikely, and I think we all intuitively expect that to some extent. But it's just interesting here to remember that that actually every year before 2020, we were experiencing coronaviruses already, and these are what we call endemic coronaviruses. They have these names that I've shown here: coronavirus 229E, NL63, and so on. And usually before 2020, we knew these as the common cold. And these were quite well established in the human population. So I'm just showing you here on the right-hand side some interesting findings from a study in respiratory samples in Scotland, And this is looking at the various influenza seasons from 2005, 2006, every year until 2016, 2017. And what they did was they basically did virological testing of each of these samples to look at the etiology, the cause of the respiratory disease. And you can see, for example, influenza, respiratory syncytial virus, other viruses. And these were human coronaviruses that were circulating in the human population in these influenza seasons well before. And so as time progresses, this virus would be expected to become more domesticated, if you like. And so even if we're not able to eliminate it, and perhaps we could, but if we're not able to eliminate it, we can expect to see COVID-19 settling into this seasonal pattern and becoming a much milder infection, one that perhaps, depending on the immunity, perhaps affects young children the most, but also becomes an additional cause of common cold. And I'm coming to my last slide now, and this is about the immediate future of COVID-19. Would it be an immediate threat? One thing I should mention is it's impossible to predict what's going to happen in the immediate future. So if we went back to the beginning of this year, it wasn't possible to predict the emergence of the Delta variant. The best available science doesn't allow us to do that. And so the same also applies for the future. So the nightmare scenario is a virus that is even more infectious and shows complete immune escape. And this is unlikely biologically, but of course, with these viruses, you can never rule anything out. Still, with mathematical modeling, we can still point to some general insights about what to expect. And at that point, I think I've spoken enough already, but perhaps I can hand over to Dr. Sandip to tell you a bit about some modeling-based insights specific to Karnataka.
Thank you. Thank you, Dr. Nim. If you can share your slides, will it be okay? I hope it's not a problem.
Absolutely. I think I sent them over just before, but yeah.
Okay, great. Thank you. Now turn to Dr. Sandip Mandal to sort of make his presentation on the modeling, especially relating to Karnataka. Over to you, Dr. Mandal. Your 10 minutes.
Yeah. Is it visible? Is my slide visible now?
Yeah, visible.
Okay.
Yeah, we can see that. Thanks.
Okay. Thank you for giving me the opportunity to present over here. So I'll be speaking on the plausibility of third wave of COVID-19 in Karnataka, especially from our modeling exercise. So it is very uncertain. Means now the recent question, current question is whether the third wave will come. We'll see the third wave, or if it comes, then when it will come, how severe it could be, and or how long it could continue. There's many questions we are facing actually. Means everybody is asking about these things, but it is very difficult to predict when the third wave will occur and how to answer all these questions. But what we can do through mathematical modeling is that we can examine different scenarios or hypotheses how the third wave will look like, the probability of third wave, specifically for Karnataka. So I'm changing my slides. Is it visible, right?
Yes, yes, it's
okay.
visible.
Thank you then. So first of all, we have developed a very simple model, not any fancy model, difficult model, different structures, but using that basic concept of epidemiological structure, means how disease propagate from one person to another in the community. So capturing all these scenario along with the age-specific mortality, asymptomatic infection, etc., we developed a model with these basic assumptions. And we tried to capture this model through the data in the reality, what we observed. Especially, I'm presenting now for Karnataka, so I'm showing here the figure is for Karnataka, first wave and second wave. Here you can see the daily symptomatic cases, what it is reported is presented by the black bar, small bar. It's a reported number, but simultaneously we have the information of seroprevalence during mid-September. From National Seroprevalence Report, we saw that this was 16% seroprevalence at the first wave during the peak of first wave. So assuming this information is true, and we can project we have projected this curve, that blue curve, for the first wave. And similarly, applying the information that the second wave was 4 times, the peak of the second wave was about 5 times higher than the first wave in Karnataka, not in the national level. National level, it was 4 times higher, but what Nim had already said. But for Karnataka, it was 5 times higher than the first wave. So accordingly, we had accordingly, we had chosen the beta value or transmission rate for the first wave and second wave. Then we can get this curve, that blue curve for the first wave and second wave. Now, with this model, what we can do that we can examine what could be the third wave look like and when it will appear. So there are 4 hypotheses we have tested here. Hypothesis 1 is why third wave can occur. Means first of all, if the immunity wanes, if fully waning of immunity, that might be one reason for occurring the third wave. Second is if new variant comes, which has the capability of escaping immunity. So then the third wave might arise. The other probability is if say new variant comes, which has capable of for which R0 value or basic reproduction is much higher than the previous one, increased transmission probability, then the third wave can occur. And the other scenario is the lockdown related scenario. In the some places where the lockdown was very strong to reduce transmission, there is a chance. There are lots of susceptible population in that places. Now, if lockdown release without any protection, without prevention, then there might be a probability of there might be third wave might arise in that places also. So in this talk, small means due to time constraint, I will only try to emphasize on the second and third scenario. That means immune escape scenario and increased transmission scenario. If new variant comes with this behavior, then what would happen? I am going to show these 2 scenarios specially. So let's see what would happen if new variant will come with higher immune escape probability. So this graph actually shows that symptomatic infection for the first wave and second wave with the blue curve, and the third wave is presented at the right hand side. Here 3 scenarios we have developed. One, if the new variant can capable of escaping immunity by 10% only, then we have examined that there is very little chance, means there is no third wave. See, the blue curve is just at the bottom. There will be no third wave at all. But if the immune escape is 30%, then the green line is occurring. I mean, there is a chance of third wave, but it would be very minimal. But if immune escape, if the virus has the capability to escaping the immunity by 50%, then there could be a chance of huge peak, though it is lesser than the second peak. If you see compare with the second peak, this would be a much lesser value than the that one, but it would compare more to the first wave. Then the other scenario, if the third wave comes with more intense R0 value, means higher R0 value. For the second wave in Karnataka, we have examined for this model specifically, R0 was 3. So now if we assume that some variant comes where R0 is instead of 3, it is higher than that, then what would happen? Let's see. So in that case, here again also we projected 3 different scenarios, R0 equal to 4, R0 equal to 5, or R0 equal to 6. In all these scenarios, R0 equal to 4 means that blue one, green is R0 equal to 5, and R0 equal to 6 is presented by the red line. In all these scenario, in all these cases, we are seeing that the peak epidemic would be much lesser than the second wave, and it is comparable to the first wave. And also we should remember that here we assume there's all these modeling are based on some assumptions. Here we assume that the new variant would come at the end of August. Accordingly, the third wave is starting from end of August. We don't know actually this point, whether it would occur in August or September or October. We don't know yet. So this point can vary also. Now let's see if some variant comes with both the characteristics, means it can escape the immunity as well as it has more transmission probability. Then what could happen? Now this is the combined variant scenario, where we assume that R0 is higher than the earlier or the second wave, say R0 equal to 3.5, and the virus has capability of escaping immunity by 25%. Then the peak is relatively high, of course, but still it is not so high as the second wave. And simultaneously, we should remember that vaccination process already have been started. So here I'm going to show you one scenario. If vaccination is about 40% of the population, if 40% of the population is covered in Karnataka within 3 months of the second wave peak, then what would be the impact of this variant, is combined variant scenario. Let's see. This here, now the red line, this is actually effect of impact of vaccination along with that new variant with R0 equal to 3.5 and 25% immune escape scenario, that blue curve, and now it got reduced with the vaccination of 40% of the population. The peak would reduce by 55%, about 55% with this scenario. So there are many uncertainties. So overall finding says that from this analysis, you can say that the emergence of, means for third wave, we need, emergence of new variant that is more infectious, and if it can escape the prior immunity, then only third wave could come. Other scenario like lockdown easing scenario means there also is possible to have third wave if we don't take sufficient precautions before easing the lockdown scenario. Then there is probability of having third wave. I didn't explain all this through this presentation, but I will share some link where you can see this thing. And from these studies, what we understand, what we think, that it is unlikely to be so severe as the second wave, as it occurred in the second wave. So it might be comparable to the, if it occurs, then it might be comparable to the first wave only. And timing is very uncertain. We can't predict the timing because we don't know where the virus, the new variant will come. And so it is difficult to predict when it will come. And ramp up of vaccination effects, that actually could reduce substantially if third wave comes, that would reduce substantially. So vaccination is important at this point. And for details information like that I can explain right now, the lockdown scenario or waning immunity scenario, if you want to go through this one publication that comes in ICMR last month in Indian Journal of Medical Research, here you can see all other scenarios, all different scenarios for national level. Actually, we have projected all the third wave scenarios here from the chromic group. And also, I would like to share with you, that's not completely done yet. This one web tool we are trying to develop. It is on the way, maybe very soon it will come. There, actually anyone for their region, it can use it. So what would be according to their guess, they can put the R0 value, means basic reproduction number of the first wave or second wave, and when the variant would emerge, when the new variant would emerge, if we can assign that date over here, we don't know. So anyone can put that value, and accordingly this simulator, this web tool will show us the third wave scenario, how it looks like and when it would come. So everything is uncertain, but depending on the region or district level or in state level, if we can assume that this might be the scenario, then we can project the third wave accordingly. So that's all. Thank you.
Sir, you're muted.
Yeah, thank you very much, Dr. Mandal. and thanks to both. I think very stimulating presentation. I think definitely there will be questions. But before that, I would like to invite Dr. Gangakhedkar to sort of take a couple of questions, first of all from me, and then we'll ask our partners. I think they have already sent us some questions. So I will field those questions, and then maybe Dr. Gangakhedkar can sort of answer them. And with his expertise in India, I think he would definitely be able to relate the community aspect also much stronger, how the communities are going to be impacted. So my first question will be that to you. What is how do we look at the problem of access of vaccination or even COVID-related services to communities, and how you find it happening in India, and where are the gaps? And even now we find those are the communities which are most impacted by the COVID virus, by the coronavirus and the COVID epidemic. So what is your take on that?
All of us know that currently the issues are surrounding these supplies as a major issue. Perhaps if supplies was not a constraint, perhaps
your audio is
vaccine would have been really.
Am I audible? Your audio is failing, Dr. Victor. So maybe you can switch. Your audio is not is failing. So maybe you can switch off your video, and then audio will be better, I think. Now you can try.
Now, am I audible?
Yes.
All of us know that India, or perhaps the entire world, currently is plagued with supplies related issue. If there is no bottleneck of supplies, what perhaps we might see is a swift vaccination that could occur. To me, in another 1.5 months time, perhaps we will have so many different vaccines that would be available in India that I still think it would be feasible to vaccinate everybody. But the fear that I would always have is, the longer we will take after the memory that has left some impact on everybody, that this particular illness is bad enough, it can cause death. As it starts waning off, perhaps vaccine hesitancy is likely to come up strongly. So we need to have a good balanced approach. We also need to ensure that 45 years plus population is first saturated with vaccines, then 18 to 45 years plus population, 18 to 45 population. Perhaps we should be in a fair position if we adopt that.
Yeah, right. There is a question to you that, see, by and large, women in India are anemic. See, so is there any empirical data shows they are more susceptible to the infections and death compared to men?
Overall, perhaps there is no known difference between all-cause mortality rates among those who are anemic and not anemic, given the fact that such issues do not make so much of complication or a difference in terms of outcomes. The issue of anemia, and if the person is trying to ask, would it affect the outcomes of vaccination, perhaps we don't have any such evidence as of now.
Okay. To Dr. Nim, there's a question. Can you comment on the impact of COVID on children and implications for the reopening of schools? This is a very hot issue in India. So can you throw some light on that, especially from your experience in UK?
Thanks, Dr. Prasada, and thanks, Anish, for the question. It's a really pressing question. When we went into the pandemic, I think there was this expectation that COVID would be quite flu-like, influenza-like, because our previous thinking for influenza was that children are important vectors for transmission. And so vaccinating school children can be very important in controlling influenza. So when we applied that sort of thinking also to COVID, of course, school closures become very important. But some of the more recent evidence has become a lot more subtle than that. There have been studies from various countries, not just the UK, which looked at PCR positive children and did epidemiological investigations to try and identify where they might have gotten infection from. And by and large, the strongest evidence for where these children got infected from was not in schools, but in the household, which was really interesting. And so there seems to be gathering evidence to suggest that schools themselves are not as strong drivers of community level transmission of COVID as we might have expected from past experience with influenza. Having said that, these studies do have limitations. They were conducted during periods of lockdown, when household exposure was actually particularly intense, whole households and families being enclosed in the same space together and so on. And recently, there has been some very interesting virological evidence, which is when you have somebody with a child with COVID and you compare them with an adult with COVID, they both have comparable amounts of virus in their upper respiratory tract. And so, just by the sheer amount of virus that these children are shedding, you can imagine there's the potential for as much transmission. So I'd say we still don't have a very clear picture. But I think to my mind at least, the overall picture emerging is that even if schools are important, they seem not to be as important as they were for influenza.
Okay, thank you. Now, Dr. Gangakhedkar, one more question to you. How can an NGO support the society by keeping in mind the consequences of this coming so-called third wave?
I think one of the first things which would be important for an NGO to contribute is into helping people to overcome their vaccine hesitancy, ensuring that they facilitate the access, because current approaches which continue to rely a little more on the digital platforms, trying to help them out, try to set up services whereby they could book the appointments and try and go there when their time is already actually there. The third thing which is also important for us to understand is they could themselves be gatekeepers of the information that tends to exist. Now, they could disseminate this information with respect to either myths, which may be prevalent in the society. The fourth thing that perhaps they can actually try and do is try to project opinion leaders, because they are closer to the community. So they know whose opinion is counted more in that particular area which they are operating into, and try and ensure that the word tends to spread, that the person is taking vaccine, and not only taking vaccine, after taking vaccine or even before, he was ensuring that he adheres to COVID appropriate behavior. I think these key messages, if the NGO could pass off, that would be extremely critical. For key subpopulations, there is a small concern. When it comes to Sputnik vaccine, the second dose of Sputnik vaccine comes from adenovirus 5. Now, adenovirus 5, when it was tested as a platform in HIV vaccine trials, they found that it increased the risk of acquiring HIV infection by almost 40%. So this particular risk actually waned off after 2 years. But for 2 years, when they had followed up, the risk was seen to be higher. The risk was increasing by 40%. Now, the implication is very simple. Now, would it actually impact us? To some extent, yes, because we have still not been able to assess the impact of lockdowns over the ART adherence at this.
I think your voice is failing, Dr. Gangakhedkar. Dr. Gangakhedkar, can you hear us? I think we probably have a here's a technical problem, I think. Okay, can we, as we get connected, let's go to the next question. I think I'll address this to Dr. Mandal. It is, will the virus get muted in strong immune response person or weak immune person? And also, how many more mutant generations possible for this particular virus? Of course, nobody can say, but
yes, very difficult question, as I mentioned before. So if we can know these things, this answer, if I have this answer, then we can certainly predict the third epidemic, what it could look like. So it is difficult to answer actually.
But the first one, will it get muted in a strong immune person or a weak immune person?
So I guess, I mean, biologically, I can't answer this actually, means I don't have that much knowledge. So I think,
okay.
Yeah.
Okay, no problem. We can pass that question.
Yeah, so I can pass the question. Yeah.
Yeah. Now, there's one question about deciphering the research conflicting data and efficacy of vaccination. You know, you have huge amount of data coming in. Some says, yeah, it's very good, very efficacious. Some data saying it's not. So how do we manage this situation, especially if you think from the point of view of government or even from the point of civil society leaders? How do we manage this sort of a conflicting research coming in, you know, about the efficacy of vaccines? Any one of you can take it. Dr. Pati or Dr. Mandal.
Okay. Should I jump in?
Yes.
Yeah, please.
Okay. Yeah, so I think the most important thing to remember when we see efficacy data is that, I mean, people tend to think efficacy data is a single number and it tells you about a single type of protection. But actually, there are different types of efficacy. There is vaccine efficacy against getting infected in the first place. There's a vaccine may not protect you from getting infected, but it also then may protect you against getting severe disease. So perhaps it protects you against hospitalization. And thirdly, even if you get infected, you get severe disease, a vaccine may protect you against the ultimate severity of infection, which is death. And so when we're looking at these different measures of effectiveness, it's always important to ask in the study, what was it that they were measuring? Was it whether people were getting infected, severe disease, or even just mild symptoms? You know, sometimes people, these trials are looking for any type of symptoms, whether they were severe or mild. And I think this is very, very helpful in addressing some of these apparently contradictory results. So, for example, there was a lot of concern about Covishield, the AstraZeneca vaccine, being somehow less efficacious than the other vaccines available, because the reported efficacy number was lower than the 95% or whatever it was for Pfizer. But the important thing to remember there was in the study that what they looked at was whether people developed symptoms or not. And instead, if you look at whether people develop severe symptoms, severe enough to go to hospital, all of these vaccines offered really, really strong protection. And so there can be different measures of efficacy in that way. And it's always important to keep in mind what it is we're looking at.
Thank you. I think that's a good answer. I think Dr. Gangakhedkar couldn't join, I think. Is he joined? Oh, you're back. Oh, thank you. Yeah. There's one question to you, Dr. Gangakhedkar. You were talking about the impact of the adenoviral vectors, in the second dose of Sputnik. But the question is, it is also present in the aged Covishield vaccine. So what are your opinion on the possibility of Covishield increasing COVID transmissibility?
No, Covishield does not. At least we didn't have that kind of evidence.
Okay.
Because this particular trial, which was done in Africa, there they had used adenovirus 5. No? Covishield is based on 2 dosages of adenovirus 26. Whereas in Sputnik, the first dose is adenovirus 26, second is adenovirus 5. So the risk could be perhaps little at least theoretical risk, because this was only a single study. We still don't have that evidence ratified now in COVID era that those who acquire it are likely to have increased risk of acquiring HIV infection. The likelihood of also acquiring HIV infection continues to be low, given that HIV incidence is expected to be low. But if we don't have the figure, either they could avoid, especially Sputnik vaccine, they could go for Covishield or Covaxin without any fear.
Okay, got it. Now, one question, of course, this is very this is more an operational issue, because the COVID has brought down substantially the cost of the RT-PCR tests. It was very high at one point of time. It has come down substantially. Can something like this happen to bring down the testing costs for viral loads for HIV, TB, viral hepatitis, etc.? We don't want those epidemics to come, but any other way of getting the cost down.
I think costs are, as it is, are getting down. The question is, if we want to bring it down further, what we will have to do is try to promote our industries to produce viral load kits. Now, if we do that, and if they start competing with the current manufacturers that are already there, like Roche or Abbott or such large multinational firms, I'm sure the cost can also come down. The question is, I think trying to promote one of our own industry groups to pitch themselves against the multinationals.
Yeah, that's right. Okay, thank you. I think this was good. And now we move to the next session where our governing council members are waiting. I think they would also have their comments and also questions to the members, to our experts. So if they are here, maybe I can't see them here, but maybe if they can just switch on the video and raise your hand, or just speak out that they want to ask a question or make a comment, I'll be able to see that. I can't see them here, actually. That is the problem. All of them.
Rao, Dr. Bhatt has left a question. It's on the sheet.
This is this grassroots organization thing. Okay.
That's the
one. Yeah. One question is that what questions should grassroots organizations be asking of their local government counterparts, and what data should they be looking for to ensure their communities are prepared for the next wave? And how can you make the communities prepared for the next wave, basically? What should they ask the governments to provide as information? Maybe Dr. Gangakhedkar, can you, or Dr. Prati, can you tell us? Any one of you?
Dr. Nimalan was already speaking.
Yeah, please, Dr. Nim.
Please go ahead.
Sure, thank you. That's an interesting question and a great question, because also data is going to be really important in local level responses. My slightly controversial feeling about this is that there has been a lot of talk about highly sophisticated data collection efforts, prevalence surveys at the community level, and so on. And I think all of these intensive data collection efforts can be very valuable, but we also shouldn't ignore the value of routine surveillance and the systems that we already have in place. And if we can make those systems as systematic and as robust as possible, that could really be one of the most important drivers of local responses. So when I mean routine surveillance, what I mean is the testing that we're already doing amongst symptomatics who are presenting to facilities who show signs of having COVID-19. There are sometimes issues, as there are in any country, about the availability of tests, about the timeliness of test results, and so on. And so addressing these so that we get as timely information as possible would be really important. So to this point, we recently, as part of the ICMR team, had a comment in one of the medical journals in the Lancet, just pointing out, if you looked at routine surveillance and the test positivity rates in routine surveillance, and use that as a trigger for local vaccination, when a particular district shows signs of having an uptick in infection, if you do it quickly enough, you can actually substantially mitigate the amount of disease burden as a result of that. And all of that being driven by test positivity rate through routine surveillance, through the amount of testing that we're already doing. So in short, for me, I think it's really about strengthening routine surveillance.
Thank you. We have the Governing Council members here. Particularly, I would like to ask Rajiv Sadanandan. He's from Kerala, and Kerala is right now in the spotlight because they have almost 50% of the infections in the country. So, Rajiv, do you like to ask any questions, or you have any general observations about this particular forecast?
Sorry, Dr. Rao, he couldn't make it. His internet in his locality is down.
Oh, I see. I'm sorry about it. Okay, no problem. So,
can you share from your experiences with West Bengal?
Yeah, I'll do that. But first, let me
sure.
let me ask any other member of the council who would like to comment or make ask a question. Okay, if there are none, I'll just take 2 minutes and hand over to Angela for the final comments. I think experience of West Bengal, I will talk from that only. I think if you really believe in science and if you tailor your response to science, I think definitely you will succeed. I have seen that happening in West Bengal right from April last year. They have, not that they have put us on the advisory board, but they also have a process of consultation with experts, taking their opinion, and also conducting local level surveys, which other governments have not done. Karnataka is one exception. Karnataka has also done some local level surveys. Taking data out of that and tailoring your response to that is very important. For example, during the second wave, we have been telling that you look at the vaccination of people who are at high risk, who are likely to be spreaders of the infection, those who meet with community people from the community, like for example the transport workers or the vegetable vendors or the drivers. People like that should be given priority in vaccination. But somehow or the other, this was not picked up as a policy issue at a higher level. But West Bengal government has done it. They have focused on these populations and vaccinated them. In fact, today I think West Bengal has one of the highest coverage of vaccinations. If you take both the doses, they have already covered quite substantial number of people by vaccination. So this is one reason why quietly I think they have been able to keep the epidemic at a lower level by doing very quiet work on the field and following the path of evidence and path of science. I think that is the message that we have for governments and also for civil society. And one important area where I think West Bengal really has been a pioneer is in terms of mobilizing the communities, especially communities who are affected by or infected by COVID. You have COVID warriors who formed into groups and organizations like the people living with HIV. Here also we have people who have been infected by COVID, and they have done wonderful work in spreading awareness among the people at large, among the communities. I think that has been a pioneering work. Some of the other many states have not been able to pick it up, but I think West Bengal has done a great job on that. So I stop there. Thank you. Over to you, Angela. And thanks again to all our experts for taking the time and joining this discussion. It has been very, 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 very illuminating, I would say.
Thank you, sir. I mean, for vaccines and for every other essential products, people who need it the most get it the last. There's really a need for a four-way partnership between government, civil society, private sector, and the media. So please use these messages today to join the #VaxNow campaign of the COVID Action Collab, because no one is safe till everybody is safe. Thank you so much to the panelists and participants for a very insightful evening. Have a good day. Stay safe. Bye.
Thank you. Thank you very much. Take care.
Thank you.
Thank you. Bye.
Thank you. Thank you.